microphone you can use or a headset for the microphone?
Use the microphone, can you hear me?
Not very well.
I'll try something else, so hold on.
Thank you.
Gentlemen, commissioners.
I believe so, yes, sir. She's just finished us. She's having some Wi-Fi issues.
Can you hear me now?
Yes, very well. And you can hear us, Doctor?
Sure can.
All right, and we're going to try to keep the right distance between us and the microphone so you can hear better than previously, okay?
Sounds good.
All right, the time has come for this meeting to begin, so I will call to order the March meeting of the Panhandle Health District, Public Health District number 1, State of Idaho. And ask that you all stand. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Thank you. You may be seated. The public comment, we have received a number. I have the most recent receipts right here, and we have read these. Thank you for your comments. We will move on to the consent agenda. In the consent agenda today, there is the minutes from our January 28th meeting and the divisional reports, which I trust you have been able to read the divisional reports. I appreciate the effort, the time that different ones from the 2 divisions spend in writing these reports. Appreciate it very much. And then there are contracts, mainly just one contract. I would ask, does anyone have any comments or questions about the one contract that's in your packet today?
Mr. Chairman,
Yes, Dr. Banks?
I move to approve the consent agenda as submitted.
All right,
I would second the motion.
been moved and seconded. I would ask any discussion. One of the things I was wondering about, Dr. Banks, if you wanted to hear any comment regarding the one policy that's item D in the consent agenda. Are you okay with that?
Well, Mr. Chairman, in order to have discussion, I think we need a motion and a second, which we have. So yeah, let's hear it.
Well, this can be a part of the discussion. We have a motion on the floor with a second, and I will, for discussion purposes, I'll call upon Laura to give us some comments that she might have on this one policy. All right?
Thank you, Mr. Chairman. So, as you're aware, we look at policies every 5 years to see if they're still solid, if they need any changes. This particular policy was written in 2003, delegation of authority to employees quarantine and isolation orders. As you're aware, in Idaho Code 39-415, it gives the District Board of Health the same authority, responsibility, powers, and duties in relation to the right of quarantine within the public health district, as does the state. This is, it certainly has never been used in COVID. All isolation quarantine is voluntary. There have been cases throughout the state of Idaho, perhaps there's an individual with tuberculosis that is not being compliant. Not here during my tenure, my 20 years with the Board of Health, have we had to issue an order of isolation or quarantine. But in the south, they have with some folks that may have had some homeless circumstances. It's quite a process, and it would never be, in 2003, it was prior to me being here, and this was put into effect. I don't know if it was because of SARS perhaps, where the board delegated this authority to the director. I would of course never issue an order of isolation or quarantine without involving the board. So to me, this is a policy that's not needed as it's in statute. And certainly it's up to you, but my recommendation would be to rescind this policy.
All right, you heard this discussion, but at the same time, we have a motion and a second. And if this motion is passed, then this policy still remains a policy. If you.
No, Mr. Chairman, I'm sorry. This was to repeal the policy.
Oh, I'm sorry. Okay. If we pass this, then this is repealed. I'm sorry, I read my notes wrong here. So, are you ready to vote? Hear no more comment. All in favor of adopting the consent agenda, indicate by saying aye.
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 And opposed, no. And is so ordered. All right. Now, on the roll call, I'm not sure whether we have Jay Nelson on yet. Jay Nelson, are you with us?
She was right there. Oh.
Jay Nelson, are you able to, there she is. Can you hear us, Jay? We are.
Yeah, and I was on earlier, I was just on mute phone.
All right, are you catching us now, Jay?
Yes, I am.
Okay, thank you. Secretary will record that we're all present. All right, let's move on to item number 5 on our agenda. And first, Jeff Lee is coming. Jeff, you have the floor for a COVID-19 update.
Go ahead and go to the second slide, please.
You're going to get some of this stuff. Cameras, hiding away. Is that the second slide?
Good afternoon, everybody. Thank you, Mr. Chairman, board members, director. Since our last little get-together back in January, things have changed fairly significantly here in our region. I'm going to quickly go over what's going on globally, nationally, and in the state. There are 123.9 million cases globally of COVID-19, with 2.7 million deaths. Nationally, we are at basically 29.8 million cases, which is 24% of the global cases. We represent about 4.5% of the population of the globe. So we have quite a few cases in the United States, over and above what other countries are experiencing. And in Idaho, we have 178,000 cases, less than 1% of the national cases, so that's good news. And our infectious fatality rate is hovering right around 1%, which is what we see locally as well. Next slide, please. So locally in our district, we are almost to 23,000 cases, less than 13% of the Idaho cases. We represent about 15 to 16% of the population, so we're doing pretty well. Of note is the 7-day incidence rate average that is now down to 10 cases per 100,000 population for the district as a whole. We had been running upwards of 50 cases per 100,000 2 months ago in the December-January timeframe. We only had 164 new cases in the past 7 days. In December, that would have been a good day, where we were running as high as 400 cases in a day. And our currently active cases have dropped from 30% of all cases ever reported to just over 7% of all cases. So the amount of virus circulating in our communities has dropped significantly. All of our counties are in yellow, which is the minimal community spread for the COVID virus. And our testing positivity has dropped down to 4%. And that's 4% through our Sentinel site, which is Kootenai Health, and the testing that is reported into our National Electronic Disease Surveillance System. That is calculated by the state, and they take all of the positives. That also, the lab reports all of the negatives, so they have a valid denominator. And both of them are running at 4%. This is below the WHO's threshold for concern of 5%. Hospitalizations, we only have 17 people in hospitals right now, and 4 of those are in ICU. But this is way better than the 90 some odd admits we were seeing in December and January, with upward of 30 or more cases in ICU. One dark spot on the horizon, we got notified yesterday that we have our first variant case of SARS-CoV. This is what's called a variant of concern. This is a California variant, and I will go into what some of the consequences of that can mean here in a moment. Next slide, please. This is our epi curve. Because the numbers were getting so high that the computer couldn't crunch them. This starts about the beginning of August, whereas the epidemic in our area goes all the way back to March 15th. We're just a little over a year out from our very first case. As you can see, since the middle to end of December, the cases have come down very significantly, where we're averaging roughly 30 cases per day intake as opposed to 400. Next slide, please. This is the graph that demonstrates the 7-day average incidence rate per county. The red line at the top, that's the threshold into the red or significant community spread. The orange line there in the middle is the threshold into the moderate. Below that line is the minimal community spread. As you can see, all of our counties, with the exception of Shoshone County, are well into the yellow or minimal community spread region. And Shoshone is close enough that we're considering it yellow because the number of cases in our smaller county don't have to be very high to trigger a large change in this metric, which is the rate per 100,000 population. Next slide, please. Test demand has also gone down throughout the district since the high there towards the end of November, beginning of December. The blue lines that you see are the tests that are performed. The red lines are the positive tests as a proportion of the test demand. And you can barely see any red towards the right-hand side of the graph, which represents here recently. So test demand is down, but actual positives as a proportion of those tests is also down, reinforcing our assessment that community spread has decreased significantly. Next slide, please. And this is just a curve of the positivity through Kootenai Health. As I said, there are Sentinel test sites, and we are down, we're below 5%. We're at 4% right now. And it has been a continuous drop since about the second week of January. Next slide, please. So, as promised, just to discuss some of the variant problems, we have 5 variants that are considered variants of concern. They've got a lot of numbers, and it's probably easier to just remember them as the UK variant. Some of the issues that it can cause, it's more easily transmitted from person to person, potentially with increased severity of illness. However, the vaccines and the therapies are still effective against this variant at this time. The Japan-Brazil variant, unfortunately, there's decreased effectiveness of some of the monoclonal antibody therapies and decreased effectiveness of the vaccine or having had a bout of SARS-CoV, the natural immunity that would arise from that, has a decreased effectiveness against this particular variant. The South Africa variant, again, pretty much increased transmission from person to person and decreased effectiveness of therapies and immunity derived from either wild virus infection or vaccination. Next slide, please. Now, these 2 variants are so close together, they're just grouped as California variant. They both have the same areas of concern. There is a slight to moderate increase in the transmission from person to person. While not all therapeutics are impacted, a significant portion of the therapeutics have decreased effectiveness against this variant. And also, we're seeing decreased effectiveness from vaccine and having had SARS-CoV in the past. This recent report, our first variant case in the 5 northern counties, is both a variant and a vaccine breakthrough. So we will be watching this very closely going forward. The 429 California variant is pretty much the same thing as the 427. They just impact different regions on the spike protein that are changed. Next slide. Any questions at this point?
Yes, Jeff. Make sure we all understand what you mean by vaccine breakthrough.
Sure. Once somebody has been fully vaccinated, and that's going to depend upon the vaccine that the person gets. If you get the Pfizer or the Moderna, it's both vaccines. Pfizer is given 21 days apart, Moderna is given 28 days apart. And then 2 weeks after that, you would be considered to be fully immunized against COVID. And when we say fully immunized, that's a relative term. The efficacies of both of those vaccines were around 94 to 95%. The difference between an efficacy and an effectiveness efficacy is in the test tube. It's what we hope to see, and effectiveness depends upon the population that's receiving it. And so it may vary from the efficacy of that we see it for the vaccines. The Janssen or Johnson vaccine is 1 dose. So it would be that dose plus 2 weeks to be considered fully immunized. And again, with the caveat that fully immunized means that there's a potential for some folks to still be infected. And that's what we would call a breakthrough infection, but not have as serious a bout of disease as they would if they were unvaccinated. Did that answer your question, sir?
Go ahead.
Yeah, I don't mean to interrupt you, but do you have any data on false positive testing?
I don't have it readily with me, but false negative testing is much more common than false positive testing.
Okay, all right. So they retest that person again?
Are we going to retest them?
Yeah, I mean, if someone tests positive, do you wait a day or two and retest them again to verify the fact that
Well,
that's
in
positive?
this case, and I understand your question, but in this case, it's not necessary. To detect the variant, they've actually isolated the virus from this person and sequenced the genome.
Chair
So-
recognizes Glenn Bailey.
Jeff, my question concerns the PCR test. Wasn't the threshold for the PCR test changed in early January, mid-January? Doesn't
Yeah.
that coincide with the drop in the number of cases?
Not
So
that
I
I'm
know
aware
at
of.
the national level, they were talking about the PCR test and the number of times that it had to be
The cycle.
cycled
Yeah.
to achieve, this is,
Do you understand what the cycles mean? So-
Yes.
And I can explain that real quick if you'd like.
no, that's
the number of
okay.
amplification cycles. So
But
the
I-
higher the number, the less the virus is there.
Yes, and my understanding was that that requirement had been changed sometime in January. Was that correct?
No,
Or bad
not
information?
to my knowledge. They may have put a limit on the number of cycles to say, yes, we're detecting a significant amount. And, at this point, they want to limit it to 30 cycles for it to be significant. So it's not being amplified as much as it was before.
Okay. Thank you.
Mr. Chairman.
Okay, Chair recognizes Dr. Banks.
Yeah, I think I can shed a little light on this. The WHO, right around the end of January, it's actually right around the inauguration of President Biden, changed their recommendation for a cycle threshold from 45 to 30. And that's expected to drop the number of positive tests by about 90%. So what we're seeing is that change in the cycle threshold, which is reflected in the lower number of positives being found.
And that was the WHO finding?
WHO and CDC both changed their recommendation.
That was my understanding.
You wouldn't happen to,
Have a reference?
yeah,
And Google it. If you trust Google anymore.
YouTube.
thank you. Any other questions?
Yeah, I have one or two, Mr.
Dr.
Chairman.
Banks.
Again,
Mr. Chairman, I
just,
can barely hear Alan. I'm not sure if his mic is on. I'm not sure about Mike or Jay, but I can barely hear Alan.
All right, thank you, Dr. McClinus.
I think it's on. Is it on? Can you hear me now, Dick?
Okay.
Okay, I'm a little closer to the microphone. Just to emphasize a couple of points. Those of us who've looked into the PCR test find it suspect. It isn't a licensed test. The only reason it can be used is because we're in a state of emergency. But that aside, we also have positives based on this faulty test, as well as probables, which are being counted as positives. And that has inflated the numbers far beyond the actual number of people that are sick. The number of people that are sick are a tiny percentage of the positives, and I think we need to remember that as we determine whatever we determine here. And I just wanted to emphasize that. So there we go. Again, just repeating myself from meeting to meeting.
Okay,
Any other questions, Mr. Chairman?
hearing none, do you have any more for your
No,
report?
sir, no.
All right, thank you, Jeff. Then we're going to call on Mr. Duffy to give us some immunization distribution update.
Thank you.
You have
Thank you, Mr. Chairman and board members and guests. Appreciate you being here today and the opportunity I have to give you an update on where we are with the COVID-19 vaccine. So as of yesterday, as of this morning actually, Panhandle Health District and their partners have received 97,813 doses of COVID-19, and that's both first and second dose. A small percentage of those go directly to our partners, and the rest are received here at Panhandle Health District for distribution. Of that 97 or 98,000, 84,000 have been delivered to our partners, and we presume are in people's arms at this time. And so we normally leave about 10% in our inventory, just to make sure we have a little room in case there's a change in the supply chain, and we have maintained that routinely. We're happy to say that we have 25 partners throughout the 5 districts that distribute or administer the vaccine. And of those, there's 38 different locations throughout the 5 counties where individuals can go to be vaccinated. You know, when we started this effort early on, as you all know, demand significantly exceeded supply. When we would set up clinics for several hundred, over 1,000 openings, within 45 minutes, those appointments were taken. We're actually now seeing a reverse of that our supply is exceeding our demand. And as you know, working with the state and our governor, we are opening up our phases so that more have the opportunity to be vaccinated. And as of today, we now will vaccinate anyone over the age of 16. And we hope that we'll see an increase in those desiring to be vaccinated as a result. We hope that we do that. If we continue to see this trend toward supply exceeding demand, we may not need all the vaccine that we're currently getting from the state. So that could make some changes. But I wanted to also just mention the number of volunteers. So Panhandle Health District, of that nearly 100,000 doses that we received, Panhandle Health District clinics have distributed over 25% of those. And we have clinics in all 5 counties that are actively administering the vaccine. We only have 6 paid employees that monitor that. The rest, which are hundreds, are volunteers. And we have a large contingent of National Guard troops that help us in this process. And then, of course, we have our volunteers associated with the Medical Reserve Corps. And these folks just keep coming day after day to help us in this tremendous effort. And I just want to be clear, Mr. Chairman, that we could not do this without the National Guard and without our dedicated, selfless volunteers. We very much appreciate the help that we receive from them. We are seeing some of our partners, our Kootenai Health, for example, is no longer vaccinating at this point. And this is the last week that they'll be doing first dose vaccinations. They'll finish up the second dose. But we really believe that with this decrease in demand, that Panhandle Health District and other partners will easily be able to absorb that volume. And, looking forward, kind of where we might be down the road with this, if this demand continues to wane, is I suspect that, and we're getting planning in gear for this, is that our Panhandle Health District clinic offices will continue to be doing vaccinating for some time to come. It'll be similar to when you call into Panhandle Health District to get your flu shot. You'll call in to get your COVID-19 vaccine. And so we're making those plans, but you know, a lot of things in this COVID world can change dramatically, that could change what's happening here today. But that's our trend, and that's where we are today. I will entertain any questions or thoughts about our COVID-19 vaccine distribution.
Okay, any questions from the board? No, this is for the board. We'll take questions from the board now. Any questions for Don?
Mr. Chairman.
Yes.
Yeah, Don, I've talked to various people around our county where I live, and there were questions about, excuse me, Dick, I'll get closer to the microphone. Is that better? Yeah, get a thumbs up. There were some complaints about the distribution of the vaccine, in that we weren't just using the regular outlets that we would have used for a flu vaccine or any of the other vaccines which might be distributed, and that it was, rather than using the normal distribution channels which have been used in the past, we were not using them. And I can't comment on the details because I really don't know what the actual distribution centers are, but I know, I remember one particular one was the particular pharmacy normally distributes the flu vaccine, but it wasn't being distributed there, it's being distributed out of a separate center that had been set up maybe a half a mile away or something. Do you have any comment on that, or?
Yes, Mr.
Do you
Chairman,
know what
Dr.
I'm
Banks.
talking about?
I think I do know what you're referring to. This vaccine was different than the flu in that every vaccine, COVID-19 vaccine provider needed to become what's called an enrolled provider to do that. So those that were once who could vaccinate for the flu, they may not be a state enrolled provider to vaccinate for COVID-19. As Panhandle Health District, we reached out, as you can imagine, we needed assistance on this. We reached out to everyone that was an enrolled provider. And that included pharmacies. And I think the individual, if I'm right in this assumption that you may be speaking of, they are an ongoing great partner for us in distributing the COVID-19 vaccine. In fact, they have a couple of sites that they then became enrolled providers, and they are able to get as much vaccine as they would like at this point, and certainly early on as well. And so I'm comfortable that we have reached out to all of our enrolled providers and they're able to distribute them. But it's not the same list as those that are able to do the flu vaccine. We also, so that's the state plan. And then there's a federal plan as well. And we have pharmacies throughout the 5 counties that are part of the federal distribution of COVID-19. And that requires an enrollment process, but we're not involved with that, nor do we distribute vaccine to them. They get their vaccine directly from the federal government, which is similar to certainly the Coeur d'Alene tribe as well. They're a great vaccinator, and they have a different source, a different enrollment process, federal program on which they receive their vaccine.
Mr. Chairman, I just had a question, Don. For my curiosity, is there a database, which I'm sure there is, of the individuals who receive the vaccine, the type of vaccine, et cetera, so that can all be tracked to see the effectiveness?
Yes, we have the IRIS program. That's the state program to track all of our immunizations. We have used IRIS, we've used IRIS for all of our vaccine long before COVID-19. And that is a fairly laborious process to get all that information in IRIS. And the state is very particular about making sure that we get all of the information you spoke of into that database. In fact, our nurse clinic manager, Christina Gavin, she oversees that. And she has been on our, once a week, we have a call with all of our distribution partners, and she has presented several times to them about how that works. And then we see the end results, so we know whether or not they're getting that data into the system.
Sure.
And follow up when they may not be.
I'm sure there was a learning curve as new providers, vaccinators.
Yeah, for those enrolled providers that did not understand IRIS prior, there was some, but most have had experience with IRIS in the past.
Good.
Good question, thank you.
Any other board questions from you? All right. On the, Dr. McGlanders or Jay, Mike, any of you have a question for Don?
I don't have a question, just again to compliment Don on his leadership. It's been a tremendous success and full of bumps as well, that Don has provided amazing leadership. Everybody's recognizing that in the state. So thanks again, Don, for being such a great commander-in-chief.
Well, as I said, thank you, Dr. McClanders, so I appreciate that very much. But as I said earlier, we could not do this without our staff and our tremendous volunteers. They make this work happen, frankly.
Thank you, Don. Appreciate that.
Thank you, Mr. Chairman.
The next item on the COVID list is the mask order that we passed on January 28th. And I will open that portion of our meeting up for discussion or possible action at this point.
Mr. Chairman,
Yes, Doctor.
I would move that we rescind the mask mandate.
All right,
Second motion.
that has been moved and seconded that the mask document of January 28th be rescinded. And that would be as of right now if this motion should pass. Any discussion?
Mr. Chairman?
Yes.
Under our order dated January 28th, paragraph 4 says, the protection of the public health and the slowing the transmission of the COVID-19 disease during the effective period of this order. And then paragraph 5, an immediate danger to the public health, safety, and welfare of the people of the Panhandle Health District requires the imposition of this emergency order. From the information that we have received, that Jeff has provided, and we've seen news reports nationwide, worldwide, there has been a precipitous drop in the number of new cases, and the immediate threat to our public health and safety is no longer there. For that reason, I would definitely support rescinding this order.
Thank you, Glenn. We'll go through the list. Tim, do you have any comments on this motion?
No, I don't.
All right. Jay, do you have any comments that you wish to share on this regarding this motion?
Yes, I do, Chairman, thank you. I think it's premature to rescind the mask mandate with the information Jeff just presented with the challenge of the new variants that are out. I do agree there's been some positive steps, and I think everyone at Panhandle for the vaccine campaign and rollout and making this trend line move a little more in the positive direction. But I think we need to continue to follow the science and the data. And right now, I think we're in a bit of a gray area. There is a rise of COVID in 20 and 30-year-olds right now. We just haven't docked the boat yet. We're very close, but we're not there yet. And I think when we, continue to use caution in our communities, we will reduce the potential for even more aggressive variants. And so it's a paradox, but I think again, it's important right now to stay on task and keep that mandate for another month, which is what our last decision in January was, and continue to monitor this and see how it goes. All the counties are still in the yellow, and listening to Jeff's cases per thousand, we're kind of on the high side of that, on the low side. Again, the virus rates are dropping, but I do have concerns about the new variant. I know this pandemic, we're all tired of it, we have fatigue. I understand that. This has come, these decisions have come at a high cost for all of us who have supported the mask mandate and the director and staff at Panhandle. But again, I think we need to follow our gating protocols that we adopted and continue to follow the science and the data, which tells me right now it's a little too soon.
Thank you. I'm going to call on Mike from Shoshone County. Mike, do you have any comments on this motion?
Mr. Chairman, no comment.
I'm sorry I missed that, Mike.
No
Oh,
comment.
all right. Dr. McLanders, do you wish to comment?
Thanks, Mr. Chairman. Yes, I clearly echo what Jay Nelson has said. We have not reached a tipping point. It is not accurate, actually, as projected by Glenn, that our threat is gone. There's worldwide evidence that second, third, fourth surge is happening. Several countries are closed, as you know. We have variants that are proven to be more communicable and cause a higher level of morbidity, that is, a higher level of illness. And we do not know the effectiveness or efficacy of our vaccines. Next, we are now opening the vaccines to our whole population. And we do not have a community demographics of vaccination yet achieved to protect the public. And so I will recognize and acknowledge that our legislators have allowed and actually somewhat propagated the idea that our county commissioners in each separate county would have ultimate authority over a public health emergency. And I agree with Governor Little's recent letter, which fears that this legislation causes potential barriers for local public health and could impair public health ability to respond in case of a public health emergency. So I recognize that continuing this mandate puts some burden to our county commissioners. But I believe that we are not over the tipping point. There's plenty of evidence for that. So I'm not in favor of the motion.
All right. I think we've given every board member a chance to comment on the motion.
Mr. Chairman, I have not had a chance to comment on the motion.
Well, I declare, I will so do.
Let's talk about the science. The CDC recently published another study. They gathered statistics from March 1st of last year through December 31st. Looking at the effect of mask mandates in the 2,313 counties in which masks were mandated, and of the 3,142 counties in the United States. Looking at the county by county data, the CDC concluded that mask mandates were associated with an average 1.32% decrease in the growth rate of COVID-19 cases and deaths during the first 100 days after the mask policy was implemented. Bear in mind, it's entirely possible that the real figure is even lower than that, given all the questionable COVID statistics. And let's not forget, they're counting COVID cases, which, as we know, is a positive test in a PCR test, which has just had its cycle threshold changed, which is going to drop the number of cases by approximately 90%. But for example, we've seen that the flu cases in the United States during the same period have dropped from their normal large number, has dropped by 98%. How many people actually believe that number? I certainly don't. How many people believe that heart disease is no longer the #1 killer in the United States? It's now number 8, having been replaced by COVID. It doesn't make sense. And the science here is that at most, we have a 1.32% decrease in cases, not illness, cases, by enacting a mask mandate. And the damage that's being done to people by wearing masks, the psychological damage, the social damage, nobody's counting that. For that reason, I urge that we rescind this silly mask mandate and let our people get back to normal lives.
Any other comments from board members?
Yes, sir, I would like to just respond to Alan. There's plenty of evidence worldwide that protecting each other with masks has reduced the incidence of influenza in the world. There, in the large view, is a large forest out there, Alan. And your look at this is looking at a few selected trees, a few selected points, which is injecting doubt into the public, and I believe it's counterproductive to public health and public safety. And so I think it's important to look at the broader picture, and that's my bottom line on your comments there. Thanks.
Okay.
Mr. Chairman,
Glenn?
Can I add something as well?
You have the floor, Glenn.
okay. Dr. McClandris, how many studies have you seen of the number of people who have died from suicide or from alcoholism or from drug use because of the masks and the other lockdowns caused by the COVID? Have we studied that?
There's no evidence of mask mandates by themselves have increased incidence of the morbidity and mortality that you just mentioned.
Bullshit.
Yeah, you're not asking the right people.
Okay, thank you.
Okay. There'll be no speaking from the audience.
Oh, really?
Yes,
Not at all?
not at all, or else you could be excused. You could be
You're
excused.
not looking to pay your salaries. Oh, I got one.
Will there be any time for public input?
Okay, this is a public meeting, and at a public meeting, you are welcome to be here. You are not welcome to speak.
I just was asking.
And that's not my rule, that's the way it is. Okay, and if you're not satisfied with that, I will just have to ask you to leave. Okay? Any other comments from board members on the motion? All right. Hearing no further comments, I will do a roll call vote. Remember that by this motion, a yes vote means that the document dated January 28, 2021 is rescinded in total. We're not changing words or shifting sentences or anything like that. This means a total rescinding of the January 28, 2021 document. Any questions on this motion then? All right, we'll start out, Glenn Bailey.
Aye.
I need either a yes or no vote.
Yes.
All right, thank you. Tim Bertling,
Yes.
Jay Nelson,
No,
Alan Banks,
Yes.
Dr. McClandris,
No,
Mike, Commissioner Fitzgerald,
Yes.
and Benoit County votes yes. The document dated January 28th, as of right now, is rescinded. All right, we will move on with our agenda. The next item on our agenda is going back to this IDAPA Rule 40P1-0101. And Joe is our man of the hour. If any of you wish to leave, we'll call a recess. We are in recess for 5 minutes. Secretary.
Yes, yes, sir.
Okay, we are back then to the IDAPA 410101, and Joe, you have the floor. And if you want to look on in your agenda, find page 26.
Actually, 25, sir.
I'm sorry?
Yours is different.
25.
I think you're.
The motion is 26, but
The front page of
Thank you. It's all the same page, just different size. Go.
Mr. Chairman, ladies and gentlemen of the board, thank you. Today I come to you to explain where we're at in our process. As you recall, a couple of years ago, the Idaho legislature did not renew the rule set. What that did was that put us into a annual rule review and submission process that was extraordinary. Extraordinary in that we've not done it before, but yet following the rule set. We reviewed those rules. We came up with a rewritten 410101, which is identical again to you. The only changes are the pagination as it's enrolled in each legislative session each year. Where we're at now is that the Idaho legislature has reviewed this rule on the Senate side and voted unanimously to approve it. On the House side, it was reviewed. There was no formal vote made. However, I believe it was passed as, the best way to describe it is as a consent item out of the House. We have a technical administrative requirement for the board to ratify the notice, which is on page 25, that we are now making this rule under the temporary rule authority that the governor has, because that's still the requirement. And then your motion, if someone chooses to make it, would be on 26, which has been reviewed by all of our academic and legal scholars to be accurate in requiring what the board would do to ratify the rule so that it may move forward and exist as an IDAPA rule in the next session at the end of this legislative session. So whether the legislature was to take it and turn it into a joint resolution, that would pass it, or this process, either way, it becomes a rule. Are there any questions?
So Joe, how many years is this going to go on this way?
Sir, I would not ever intend to know what the legislature's intent was with regard to rulemaking.
Really?
No, I would, I don't know that Jimmy the Greek would ever lay odds on that, no, sir. This has been an unusual process, it's been a laborious process. I think it's ironic that the Red Tape Reduction Act led to me doing far more bureaucratic hurdles and cheetah flips than any process in the past. But I'm proud of the staff that we actually did do quite a due diligence on our rules and on reviewing them and on reducing things so that we have a rule that is pretty streamlined and it does what it needs to do. I believe the quote from the Senate chair was local ideas. Oh, I'm sorry. Go ahead. Come on, Mark.
Mr. Chairman, this is he stated this is a great example of a local solution to a local problem.
Yes.
Well, it'd be nice, or a lot of other issues, local people could solve local problems. Go ahead.
Mr. Chairman.
All right, Any questions for Joe on this?
Joe, so after all the hurdles you've jumped, you come up with the proposed motion here, is that correct? That you
Yes, sir.
would like us to,
That's the one that's been reviewed by Bureau of Administration, the Attorney General's office, and that's the one that boards, this language is what boards' motion should look like in order to adopt the rule that they're ratifying.
okay, very good. So, Mr. Chairman,
Yes.
based on Joe's explanation and the many hurdles they've jumped, I would propose the following motion. That pursuant to section 67-5226 Idaho Code, the governor has found that temporary adoption of this rule is appropriate to protect the public health, safety, and welfare of the citizens of Idaho and confer a benefit on its citizens. These rules implement the duly enacted laws of the state of Idaho, provide citizens with the detailed rules and standards for complying with those laws, and assist in the orderly execution and enforcement of those laws. The expiration of these laws without due consideration and processes would undermine public health, safety, and welfare of the citizens of Idaho and deprive them of the benefit intended by these rules. Therefore, we are adopting this temporary rule to be effective upon scene die of the 2021 session of the Idaho Legislature. The approval is conditional and will only become effective if the rules are not otherwise approved or rejected by the legislature and/or not extended pursuant to the Idaho Administrative Procedure Act, including sections 67-5291 and 67-5292 Idaho Code.
Is there a second?
Mr. Chairman?
Yes.
I'll second the motion, please.
All right, Mike seconds. Now, any discussion or questions on this motion that's just been read to you? All right, if there are no questions or discussion, I will call for a vote. All in favor indicate by saying aye.
Aye.
And opposed, no. Just like that, Joe, you have your motion.
Thank you, Mr.
Good job.
Okay. Glenn, we need some words, how things are going with the executive council and the trustee report.
Thank you, Mr. Chairman. As I think we can all attest to, the COVID-19 pandemic has caused a lot of consternation and changes, both citywide, countywide, and statewide, and at the federal level. During this year's legislative session, our both the representatives and our senators have been concerned as well regarding the processes, some of the mandates that have come forth, et cetera, and that their concern over the way those things were implemented and put into action has caused them to come up with proposals for rules changes and for changes to Idaho Code. And that's been a big part of the discussion that we have had. Normally, during the legislative session, the executive board will meet on a weekly basis. Well, this year, we've met 2 to 3 times a week. And there's been a lot of discussion. And I must say, our attorney has done an excellent job in keeping us up to speed, informed on the legislative intent and where they're at. Also, we've received help from the Idaho Association of Counties and their work with the legislative members. So it's been an ongoing process. If you could turn to, let's see, it's gonna be page 37 of the information we've been provided. This is Senate Bill number 1060 by Health and Welfare Committee relating to the public health districts and is amending sections 39-414 Idaho Code to provide for the approval and extension of certain orders and to make technical corrections and amending section 39-419 of Idaho Code to provide for an infraction to remove provisions regarding associations and corporations to make technical corrections. This is something that has been labored over and worked on quite a bit. And the bottom line, as it says here in the underlying portion of paragraphs 2, an order of the District Board of Health will take effect immediately. However, notwithstanding provisions of this subsection, if an order applies to all persons in a county or a public health district, the Board of County Commissioners within each affected county, after consulting with the District Board of Health, will determine by resolution whether or not to approve the order within county limits within 7 days of the date of the order. If the Board of County Commissioners approves the order, then the order will take effect immediately for a period of 30 days. Thereafter, the order may be extended, amended, or modified and reimposed for 30-day periods, subject to approval by the Board of County Commissioners. This was passed, and the governor signed it with a caveat that he was concerned that if there was a future epidemic, something that needed immediate response as concerned by the health districts, that they should have the authority to be able to do that. So that's why he was reluctant to sign this. This states that the health districts can do that, but they need to run it through the Board of County Commissioners, because there's control, et cetera, involved here in authority to do things. So the health district directors, districts have the authority to do that, but it has to be approved by the county commissioners. And I think this was an appropriate resolution to what we've seen during the COVID epidemic. And I think this will satisfy the county commissioners as well as the directors of boards of health, which I think they've all given their nod of approval. So the next item for discussion, or that we've been discussing, as the executive board, has been House Bill number 316. And there's a lot of changes included in this one. And the IAC director, Seth Briggs, has done an excellent job in coordinating these changes and proposed changes to the directions that we have. And I think that he's come up with an excellent product, and I think it will probably be passed as well. We'll see. Right now, it's being considered, but our legislature's on a 2-week break because they had a COVID outbreak among the legislators. So this will be taken up again. I don't know if it will be passed or not during this, or whether they're gonna let it die. We will see. But I think everyone has had a chance to review it. It talks about the funding of our health districts, about the authority of the directors of the health districts, their powers. And a lot of changes here, about counties funding the health boards versus the state funding the health boards, and the source of those funds. So there's been a lot of discussion with the county commissioners, with the directors of the boards of health. And so that's pretty much where we're at. Laura, I would invite you to make a few comments as well.
Thank you, Mr. Chairman. And Glenn and I have, as he stated, we've sat on pretty much every Friday morning calls and a couple of times, twice a week calls to talk about these. How 316 came to be, truly the health districts were bystanders of this. In my opinion, it was, the legislature has long wanted the counties to pay a portion of Medicaid expansion to the tune of about 12 million is what my understanding is. The Idaho Association of Counties was tasked by Representative Vanderwood and Wood to come up with a solution. So they looked at what the state appropriation to the health district was. Turns out it's about 9.8 million for all 7 health districts. Our portion of that is about 13 or some percent, about 1.2 million. And it essentially takes away the state appropriation and mandates, if you will, that the counties pick that up, that FY20 level in perpetuity. So it essentially doubles what the counties will be asked to provide to the health districts. And it assumes that with the elimination of the CAT, or the sort of elimination, that's very unclear, will protected hold still be a part of that? The CAT fund and the indigent fund, that the counties will have these savings. I've spoken with a few commissioners, Kootenai County Commissioner Chris Filios weighed in on this, and he's very opposed to it, in that he thinks it will be a difficult thing to put that additional burden on the taxpayers locally. So, you know, the trustees, again, this was, as Mike Kane, the council stated at the House hearing, or at the Senate hearing rather, the HAPA hearing, they had to continue that hearing when they resumed session mid-April, in the second week, the first week of April, 6th April, is that this was really, it came fast and furious. The hospitals, of course, are opposed because it leaves them holding the bag. And then the question of protective holds, that's very unclear. And if indeed it doesn't cover protective holds, then IAC has verbalized they're gonna back out their support. So I spoke with Glenn about this at trustees, all because it was, this is the way it's gonna be. And really the most you can do is be neutral when you're working with the legislature, but the trustees chose to provide unanimous support to this. But that was before we knew about the protected hold piece and the opposition, the stringent opposition from especially the small little critical access hospitals. So, I mean, this is not a binding thing. It really doesn't mean much other than I would be able to go back to my peers and IAC and let them know that our board was not in support, or it was mixed. So I would ask for your, for a vote on this. Do you approve of this going forward or not? It certainly isn't our decision. The Senate Health and Welfare Committee will be bringing this back up. They heard folks in favor of it. They'll hear the opposition, which there seem to be there are 6 or 7 folks lined up from hospitals lined up to speak about this. So really, it was a very quickly written bill, And indeed, maybe it needs study. I believe, this is my personal opinion, that let's sit back and look at this. Are there unintended consequences? Is there a way that it could be a little bit better written? And versus going at this right now, in a time when the hospitals are stressed beyond relief because of COVID, and the health district, there's a little bit of stress going on there too.
Okay, Commissioner Tim,
Yes.
I don't imagine there's any time that's easy to become a commissioner. But you have become a commissioner at a time when I would say it's particularly difficult to jump in
It's,
to this position with COVID and now with this. But specifically, do you and your commissioners up in the Boundary County, do you have thoughts you would like to share with us on this?
I would say that there's so many different laws that are coming down through the legislature, and they want to, they're trying to, they think we're making too much money as a county, and they want to take some of that back. And far as to go and to support something like this, it needs to be studied better, absolutely, before we can go ahead, because, yeah, it's, like I said, it's poorly. Yeah, right. But yeah, my timing is impeccable.
Yeah. Okay, Commissioner Mike, I want to hear your comment.
Yes, Mr. Chairman, in its current form and understanding that it has a lot more debate, I don't think that it's appropriate at this time to take action on it. As Laura explained very well, it is a negotiated item which has to do with a lot of different revenue streams to the counties. What is ultimately going to be held in reserve, or what is ultimately going to be replaced, or what is ultimately going to be taken away, may change from now. So I personally don't feel at this time, until the legislature reconvenes and they have extended debate, and we allow our Idaho Association of the County to continue the discussion, that taking action on it today is needed, or actually I think it's a little premature. Thank you, Mr. Chair.
Okay, we've heard from our two county commissioner representatives. Any comments from other board members on this? We are asked to vote whether we want this to go forward or whether we want this to be studied further.
Mr. Chairman?
Yes.
Well, two comments. Number one, they closed the legislature because 2 people tested positive, and neither of them was sick. I just want to point that out. Another case of positive tests, causing government to overreact. But all that aside, I think Glenn Bailey deserves a huge thank you for all the time that he has spent as trustee. I can't believe the amount of time that he spends, and of course, he isn't paid for that. He's a volunteer, and my hat's off to him for that. It's a huge effort, and a lot of thought and a lot of discussion has gone into the input from the trustees and the executive council. I kind of agree with Mike Fitzgerald that maybe it isn't really appropriate for us to be voting on this at all. This is a legislative issue, and let's let them do their job.
All right, I don't think that anything says we have to vote. We can always just say, let the records show that no action taken. Is that your consensus?
Still some question marks, some questions to be answered before we could support it or oppose it. So, and I think we're wait and see mode.
All right.
Mr.
The
Chair.
Secretary will just simply say that, was there some other comment?
Yes, I do believe though that having it on our agenda was most beneficial, and I appreciate it being put on there. Thank you.
All right, do you want any type of a motion at all, or Commissioner Wright? Or just,
No, Mr. Chairman, I'm not endorsing to take action.
all right? I think just no action taken, does the job. Now, let's back up. Is there any, no action is called on this 1060, but I wanted to know if there are any questions or comments you have on this 1060.
Mr. Chairman, if I could ask
Yes.
a question of our director. My understanding is as written, the consensus is not in favor of this legislative intent as written. Isn't that what I heard you say, Laura?
Mr. Chairman,
Yes.
Dr. McClimus, you're referring to 316, right?
Yeah.
No, what I'm hearing, I mean, there's varying opinions, right? The intent was to have the counties bear some burden for Medicaid expansion. In doing that, they thought that, or at least as this bill is currently written, that they would essentially double what their, the state appropriation would be no more, and the counties would be responsible for funding the health districts. And putting in perpetuity the FY '20 level of state funding. When Health and Welfare Committee of the Senate reconvenes on 6 April or whenever they choose to take this up, I don't know what they're gonna do. I just, what Glenn is responsible for as trustee is talking to the other executive council members, the other trustees. I thought that a discussion so he could understand how everyone felt and how some of the counties felt. I know that we have Commissioner Bill Brooks, I see he's on Kootenai County right now. But I know Commissioner Filios has raised some red flags with this about the burden that it would create for the taxpayers.
Mr. Chairman.
Yes, go ahead.
My hesitation is we do not know whether they're going to want the CAT funds from the counties and the indigent funds from counties to fund the health district. Idaho Association of Counties, Seth Brigg, has said that their study shows that all counties would come out ahead by doing this. But I haven't seen all the figures yet. I haven't been persuaded completely that that's true. He said with the exception of District 7
And Bonner County, sir.
and Bonner County, that would be true. So that's why I would hesitate to support this until I see what the legislature intends to do with the funding and what they would be providing to the health districts, but what they would be putting back on the counties to fund. And I don't know that Bonner County could do that.
Right, and Mr. Chairman?
Yes.
The other thing that this legislature does, and this was really, I think, the result of a director or two that were upset with DHR and having to go through DHR for public or for personnel matters. They essentially give us the option of not participating in DHR. To me, that's putting the organization at risk. I think DHR is a great check and balance. I appreciate their classifications, I appreciate their guidance. Were this to come to pass at, either now or later on down the line, my recommendation to the board is, let's not go away from DHR, Department of Human Resources.
I'd like to go back, Glenn, to what you said. Why does it sound like, and I have no facts, figures, statistics, why does it sound like a situation where the state it in a very subtle way is trying to take more than they're giving.
It's the same old story. That's what the county commissioners have been battling all along, is the state trying to get more of our tax revenues, but we're having a hard time just managing our road and bridge, the services that we provide, the sheriff, law enforcement, with those funds, when the state wants us to shoulder more of the burden. And we just don't see, or county commissioner just don't see where that.
Well, Tim, you're new, I'm old. But in all my years on this board, I have never yet heard a county commissioner come to this, on this board, say, we have more money than we know what to do with.
That's the consensus down south, is that we have more money than we're just spending it, believing and everything. Yeah, but it's tough to even keep county workers on road and bridge. They can go out and get a higher paying job and just to be competitive with their wages.
No, they see the population boom, people moving in, and they say, we are getting all those tax funds. Yeah, now we've got to provide more services, more roads, more sewer projects, all kinds of things.
Okay, does anyone know what the position is of some of the legislators in our 5 northern counties?
It's mixed bag.
Is it? Okay, all right, well, shall we move on?
That's all I had, Mr. Chairman.
All right, thank you. Don is going to share with you some of his thoughts and concerns regarding our home health section.
Yeah, thank you, Mr. Chairman. I appreciate the chance to talk about something other than the pandemic and really getting back to why, some of the important services that we provide to our community. And of course, for 50 years, Panhandle has had a home health service. And just to make sure we're all understanding that, so that means we have registered nurses, physical therapists, occupational therapists, speech therapists, and bath aides that go into the homes of individuals and treat them in their homes. That is keeping them out of the hospital, it's keeping them out of long-term care facilities, and they're being treated at home. That's the service that we provide to so many. Currently, we have a census of 85 patients that are receiving that treatment, and they're in all 5 northern counties, and frankly, they're in every corner of our county. And as you've noticed, and as Laura and I were talking about this, you will notice in the reports that Christine provides to us that we've been struggling to keep the budget this year. And there are certainly some clear reasons why that's happened, and I wanted to go over that with you and kind of share my opinions of what might be down the road for home health. First of all, COVID-19 did affect us and continues to affect us. And the reason for that is that hospitals, as you remember, hospitals were at and above their capacity. So they were discharging patients home, patients that had very high acuity levels. Medicare and other insurances, they just pay us based on the diagnosis. If they've had a hip replaced, they pay us a certain amount. They don't pay us for time that we're in treating those patients. So because of the high acuity level, we were spending many more visits than normal to care for those patients. We also had a new billing model that the government has implemented called PDGM, or patient-driven grouping models, that's affected the way in which we bill for service. In the past, when we would go in to begin a patient, the insurer would pay us half the amount that we would get, and the other half when treatment was completed. Now they wait for treatment to end. And so we have all these expenses incurring before any dollars come in. And we're seeing that in our accounts receivable. Our accounts receivable is over $60,000 higher than it normally is because we're incurring these charges waiting to receive payment. And that's been a significant learning model for Medicare themselves. They have delayed payment just trying to better understand how they pay under PDGM. We also had a change in software, and we've also seen a decrease in admissions, a decrease in patients. We have a lot of very, very good home health agencies in this community. And they are very business oriented. They do a lot of active marketing to get more home health patients. So we've seen that as a change. And we've also we've seen a change in payer mix in terms of those that are able to pay for their services. So that being said, where do we go from here? Panhandle Health District does not want to compete, and nor should we compete with other home health agencies. But we have one serious challenge that has been part of our home health since the beginning. And that is that we see patients that other home health agencies simply will not see. In Kootenai County, we estimate that that's 25% of the patients that we see that other home health agencies will not see. In our outlying counties, particularly remote areas, it's anywhere between 50 to 75% of the patients other home health agencies will not care for. And there's a number of reasons. I think if I could, just in one line, they take patients that are easy, close by, and they're profitable. And I'm not faulting them for that at all, not one bit. They're trying to run a business. One clear example where we're different than most other home health agencies is they pay their providers by visit. We pay an hourly wage with very, very good benefits. So there's a different motivation as you kind of look through that. So as we look at home health, we continue to have the vision of what makes us different is that we see patients regardless of where they live in the 5 counties. We see them regardless of the patient's ability to pay. And we see them regardless of their health condition and acuity level. And that's important because PDGM encourages in and out. A quick check, couple of visits and out. And as a result, more than ever, patients are being shifted to Panhandle Home Health because other agencies will not see them. If I may, Mr. Chairman, I did ask our staff to give me a few examples, and if I may just read a few of these. It's frankly heart-wrenching. An 83-year-old who lives out of town on a dirt road off Spirit Lake Cutoff Road, who has been admitted several times to Panhandle Home Health. She has had multiple strokes leading to aphasia following cerebral infarction, expressive language disorder, and increased falls. Patient also has other diagnoses such as diabetes that can be present. Patient is a do not resuscitate and would like to remain at home. Over the years, we have done just that. The patient has been admitted to the hospital, but always when they return home, they come to Panhandle Health District. Another example. Lori had a recent below-knee amputation. She has a history of poor compliance due to drug use. Often drug use patients they almost all, frankly, come to home health because they're not compliant. They take a lot of time, consequently are not profitable. She has completed PT successfully and is not ambulating and is able to walk mostly without a device now. Nursing continues to see her for other medical issues. John lives in Coolin. He suffered a severe injury to his left leg in a car accident. He lives in a travel trailer and receives his PT in his neighboring shop. He continues to improve in mobility and will require a few more weeks of PT to achieve movement available with his brace. In Post Falls, we provide nursing and PT for a 15-year-old. She is paralyzed as a result of cancer and developed stage 4 pressure ulcer. We are the only agency in the area who will see her. I have 15 more of these that I could share with you, and these came in one day from our providers. So I know that this is a public health issue, and it's changing. But because of that change, because we're seeing these patients, we will continue to struggle reaching our budget. Now, we do have a couple of things that we can do to help with that. We are going to make some pretty good changes in our staffing so that we can still provide this care that I believe will have a positive effect on decreasing some of our costs. And we, as I mentioned earlier, as Medicare and as we better understand this changes in our payment model, reimbursement will be better. But the fact that we will still struggle financially is true. And that struggle means additional funding from our state and local resources to continue this program. But Mr. Chairman and members of the board, if half of our patients, half of that 85, if we closed our doors, half of that 85 not being able to get care, certainly there's personal reasons that they should have care, their ability to be at home with some dignity. Those patients will go to our hospitals. Those patients will go to our long-term care facilities, or they simply will not get care at all. So I understand, Mr. Chairman, there's no decision that we're going to make today, but Director Whalen and I just felt the need to present to you the status of home health. I think financially it will get better than what you're going to see today, but I believe the funds that we use to help these patients is imperative to continue here in our community. So that's my brief presentation. Any questions or comments from anyone, I'd be happy to take them at this time.
Mr. Chairman, I have a comment in response to Don. I'd like to put from the medical side and from the public health side, commenting how well you summarized the issue, Don. On our inpatient service, we manage 15 to 18 patients at any one time. These patients are discharged, most of whom need follow-up care, most of whom are high acuity, and categorically, the other home health agencies are definitely, we see, all about easy, close by, and profitable. This discussion has come up among all the board members over my many years on the board, and I definitely support District 1 continuing to manage our home health agency. By definition, we become the safety net, and in doing so, we prevent readmissions, and we prevent admissions, not only to the hospital, but to long-term care facilities, which are not only difficult emotionally and spiritually and physically for patients and families, but very expensive. So I'm very much in favor of our district continuing and doing whatever we can do to manage the finances needed to remain the safety net. Thanks, Don.
Mr. Chairman.
Any other comments? Yes, Dr. Banks?
Yeah, I certainly echo what Dick just said. This is actually one of the more popular programs that the health district has. I always hear positive comments about it when I talk to people. The question I have for you, Dawn, is, I probably haven't looked at it as closely as I should have, but in these bills that have come out of the legislature, particularly 316, where it says that everybody has to have some kind of insurance. Now, plainly, the for-profit home health agencies are tapping into those funds, and presumably the health district gets reimbursed by those same insurance funds. Is that true?
Mr. Chairman, Dr. Banks, yes, that is true. We all bill the same entities. However, there's some insurances, there are still patients without insurance. That continues to happen. And those aren't patients that generally other for-profit entities want to see. Also, we'll see them sending over to us a lot of their Medicaid patients, where all they have is Medicaid. This 15-year-old I just gave you that example for is one of those. Because Medicaid is not a great payer in spite of Medicaid expansion. And then we have other insurances like Humana that don't pay well. They pay far below even Medicare pays. And we have businesses out there that just don't choose to see those patients. And for whatever reason, the Humana group continues to rise here in our community. So our payer mix, even though we all see the same payers, is not as profitable. It's not as profitable a mix as other home health agencies have at this time or enjoying. Hope that answers your
Yes.
question.
Thank you. Yeah, that was helpful. Thanks.
You bet.
Thank you, Don. Unless there are any other questions, I could comment, but I won't. It's already been said. The one thing you will have noticed in this presentation, Don has spoken from the heart with passion.
Yes, sir, I have. And, you know, anytime we could get a quote from you to put on our literature, we like that, Commissioner. So I know how you feel about home health, and we very much appreciate that. So thank you for your time today.
All right, moving on. We will hear from Christine. Or are you around, Christine? I see your name up there.
Mr. Chairman, I would think she is right outside the door, but there she is.
Oh, here she comes. Come on in. Water's fine.
I had to run back upstairs and get my mask. Here, you want this? Thank you. Well, as we do with each board meeting, we'll start with our cash. We're reporting for the 8 months ending fiscal year 2021, February. We ended with a cash balance of $4,513,000. Which gives us 4.31 months in reserves before we account for board committed funds and program restricted funds. Once we take those into account, both board committed funds and program restricted funds total $616,000. Once those are subtracted, then we have 3.72 months in reserves. Please keep that 3.72 months in reserves in your mind's eye. We'll want to discuss it when we look at the draft budget for fiscal year 22.
Christine, You're more than 6 feet away from most people. I'd say, go ahead and take your mask off. None of us will be worried about it.
Thank you very much. I appreciate that. So our budget to actual is really quite easy to report this month, especially since we've done the budget revision for the COVID expenditures. Currently, our total revenue is under budget by $592,000. Don just did a very nice presentation on home health. Half of that is a result of home health revenues being down. Another portion is related to clinical, because we haven't been able to have the traffic, the visits coming in as a result of COVID. Our contracts and fees are also down, and the majority of that is related to our ICP program. In fact, our contract revenue, the variance is all pointed towards ICP, and they simply haven't been able to have the community outreach that they typically do. Total personnel expenditures, right now, we're under budget by $620,000. Operating expense, we're also under budget by $628,000. Total capital expenditures, we're also under budget by $74,000. What's occurred since we last met is in the fiscal year 21 budget, we had 2 vehicles purchased, and that purchase has been completed. We're over budget in trustee benefit payments. If you recall, we made a $36,000 payment to for the governor's trust fund, and that was a pass-through, a payback, and that payment was to the city of Kellogg. So in total right now, we are under budget by $1,279,000, bringing total expenditures to $8,374,000. We have an excess of 1.1. Once we adjust for our accounts receivable, the change in accounts receivable, add back our beginning cash balance, it brings us back to our ending balance as of February of $4.5 million. If there are no questions on this, Mr. Chairman.
Could we go back? Help me understand what the issue is with ICP.
ICP, there's really no issue. We're just under budget in contract revenue. And the contract revenue for ICP in total, our grant revenue is under budget by $216,000. And ICP makes up the majority of that. And they are under budget by, let me find it, $255,000 for the year to date.
Just help me please tell me that ICP is not costing us.
No, it is not.
Okay,
It is not.
that's what I want to hear.
All of their contracts are cost reimbursement, so any activities that they do have, we do bill for.
Okay.
They just haven't been able to have as much in activities this year. Are there further questions, Mr. Chairman? Then we will move on. To our estimated budget for fiscal year 22.
Mr. Chairman,
Yes.
if I might, apologize, as a reminder to the board, the budget, process, if you will, is, generally or historically, in March, we bring you a draft budget. It may not look like this when we present it for action. This is not an action item, this is just for discussion. We'll present it to action for you at our April meeting for approval to go forward to the budget committees. And at that point in time, after, the board has approved, the budget that we submit, for FY '22, we make our, rounds to the counties before the budget hearings, which will be at our May meeting. So the week of 26 April, we'll be going to all of the counties, to meet with our commissioners. In Shoshone, Mike will be there on 28 April at 11, and Boundary 26 April at 1:30, Bonner 29 April at 09, Kootenai 27 April at 1, and Bettawa 26 April at 09:30.
So here we have our draft budget. What we have is our fiscal year 21 original budget in the far left column. We have our COVID budget, which we addressed at our last meeting, for the total revised budget of $14.6 million. Our fiscal year 22 budget, draft budget, is $14,145,000, a decrease of $507,000, or a decrease of 4%. What I would like to do first is start with the revenue and address that. Then we'll look at the expenditures. So last year, we had budgeted $40,000 for board committed funds. Nothing is budgeted for fiscal year 22. We've budgeted $18,000 for program advances. Last year, we had budgeted $50,000. That number may change a bit. Licenses and fees, we are currently budgeting, and this is environmental, we are budgeting $2,128,000 compared to $1,650,000 for fiscal year 21, an increase of $478,000. Health services, we're budgeting $2,377,000 compared to $2,800,000 in fiscal year 21, a decrease of $453,000. Now, one thing that we do need to remember is that fiscal year 21, we had budgeted for a full FTE, a nurse practitioner. That position was not hired, so of course we don't have the revenues in fiscal year 21. So essentially, if fiscal year 21 would have been over budgeted, since we made that anticipation, that nurse practitioner would have generated fees that we had budgeted in our health services of $2,800,000. Contracts and grants, we're budgeting $7 million compared to $7.5 million, a decrease of $456,000. The majority of that would be COVID, about $600,000 is a decrease for COVID. But the offset to get to that net is the HRSA grant that was not budgeted last year and is for fiscal year 22. It's a three-year grant for $1 million. So about $300,000 is budgeted in fiscal year 22.
What's the HRSA?
HRSA is, I actually typed it out in anticipation of that question. I can just find my note.
Don't know all the acronyms yet. Sure.
Mr. Chairman?
Yes.
While she looks for that, I don't know, health resource, whatever HRSA may stand for, but what the $1 million is for over the 3 years, and you've heard from Kelsey Orlando on the substance use, the prescription opioid reduction grant, in working with our community partners in all counties to reduce the use of opioids.
Health services,
Health resources and
health resources and
services.
services administration. Federal.
And it's through the U.S. Department of Health and Human Services.
Okay.
Thank you, Dawn. So donations, I rounded up to $33,000 compared to 31 last year, $1,700 change. Interest has dropped significantly. I budgeted $27,000, a decrease of $6,000. And if you look at where we are currently in February, this will be pretty much on target to what we can expect for fiscal year 21. So really no change in what I anticipate being close to actual for this year. And county and state funding for budget purposes, I left it the same as fiscal year 21. If there's no questions on the revenue section, we'll move up to the expenditures.
Mr. Chairman,
Yes.
I do have one question.
All right.
Christine, I noticed that the license fees has a large increase in anticipated revenue. Could you explain that 22%, please?
Yes, that is the environmental fees. And currently, we are experiencing significant activity in environmental. In fact, right now, they are, for the 8 months in fiscal year 21, we are $200,000 over budget. So based on conversations with Joe and the rate of activity, the rate of construction that we have in the community, we're comfortable in anticipating an increase of 22%.
Perfect. We're experiencing that now and projected in the future. Thank you very much.
So now we will move up to personnel. Total personnel budgeted is $10,100,000 compared to the revised budget of $10,382,000, a decrease of 3%. What the fiscal year 22 budget includes is it's budgeted based on 137 FTEs, of which 18.7 of those FTEs are COVID related. So if we back out the COVID related FTEs, that gives us 118.3, which is a decrease of 0.71 FTE compared to fiscal year 21. So essentially no change when we compare the original budget to the draft budget for fiscal year 22. What's in salary and wages in this 6.81 million is a 4% increase for employee compensation based on the governor's fiscal year 22 compensation plans. What's included in fringe, health insurance went up. It increased from $11,650 per position, qualifying position, to $12,930. That's what accounts for the $74,900 increase in fringe. So once again, total personnel, $10,100,000 compared to the revised budget of $10,382, a decrease of 3%. Looking at operating expense, the fiscal year 22 budget is $3.3 million compared to $3.6 million in the revised budget, a decrease of 10%. A good portion of that $336,000, remember it's a net amount, is we're not carrying or budgeting the same amount for COVID for the actual expenditures that we incurred in fiscal year 21. We're anticipating that hopefully COVID is behind us and we're winding down. Included in this, what we need to remember again, is the HRSA grant. There's about $200,000 in there for HRSA-related operating expense.
Just have a quick question, Christina. Operating expenses, anticipate fuel increased charges for the coming year?
You know, I kept fuel probably about the same, with possibly a slight increase. I decreased overall travel expenditures because I anticipated that the program people would not be traveling because of COVID. It won't be up to speed like it has been in years past.
Okay.
So I kept that flat or a little less.
Okay. But as the COVID is dropping off, don't you anticipate there will be an increase in travel?
Possibly, but we can always budget more.
Okay.
But what's interesting is I'm really curious to see if travel will increase to the level that it used to be, since people have found how successful remote meetings
Zoom
can be.
meetings?
Mhm. Yes, Don,
Mr.
Mr. Chairman.
If I may make a
Yes, Don.
Let's comment. You know, one example of this is the home visiting program, for example, where our RNs and our parents and teachers folks go into homes, and they're
Don, if you really want the other folks to hear, I need you to come up and speak into one of these microphones.
I knew that, I probably wouldn't have raised my hand. So, just real quick, so on Glenn's question about travel. So this entire year in our home visiting program, our nurses and those with our parents as teachers program have not been traveling, going into homes at all. They've been working from their home primarily. Those two programs are looking like within the next 3 months that those programs are going to now allow them to get into their homes. So that will definitely increase our travel. But other travel like home health, that'll remain the same. They have continued to visit with lots of preventive precautions, but that's one program that will change our fuel expense.
Okay. Thank you, Mr. Chairman.
And Mr. Chairman?
Yes.
Just to point out one other thing, Christine, if the environmental, if the numbers of permits and inspections and so on go up, they're gonna be out driving around, going to the building sites.
That's true.
Site inspections.
So anyways, just something to think about, I just point that out to you.
I appreciate that input. So I'm going to go out of sequence here. We're going to save capital expenditures for last. We're going to look at trustee payments, and that is budgeted at $80,000 compared to $2,300 last year. Two reasons for that. Last year was under budgeted, and a good portion of this $77,000 is the Public Health Preparedness Department for the Regional Healthcare Coalition. So in fiscal year 21, to use it as an example, they received in their award $70,000. And that money was earmarked specifically for Regional Healthcare Coalition. And when I spoke with the program manager, he anticipated that it would be about the same, maybe less. He threw out a $50,000 number. So for budgeting purposes, I included $50,000 for Regional Healthcare Coalition, and then the remaining amount is related to the Regional Behavioral Health Board. Since a lot of that money is a pass-through money, we will oftentimes pay, as an example, St. Vincent de Paul to assist them in transitional housing for individuals. We'll support their utilities, that sort of thing, which is within the grant guidance. So now, let's discuss capital expenditures. I've budgeted $621,000 compared to $600 last year, a $21,000 increase. If you recall, the Hayden Lake facility, the loan reset to 0% interest rate. It resets in 5 years, and that 5-year period will be September of 2025. So what I did is, now remember the cash balance of 3.72%, the cash in reserves. I budgeted for principal payments as they currently exist for the Hayden facility, plus the principal payments that we're currently making on the Sandpoint facility for the year. So there's $336,000 being budgeted for capital payments. If we make, at the end of the fiscal year, and we'll watch our cash balance closely, but I anticipate that when we meet in May, we're going to ask to make a $225,000 additional principal payment on the Hayden facility and pay off the Sandpoint facility, which that balance by the end of the fiscal year will be about $45,000. If we do that additional principal payment and make the payments as budgeted, we will be able to pretty much right on that date have the Hayden facility paid off. But I would propose, and we will continually have this conversation, I would propose as funds become available, if we can, go ahead and make additional principal payments each year depending on our cash balance. So in May, there's already 225, let's say 50 for Sandpoint, I'm rounding. There's $275,000 that I think will propose payments be made. But also, if the cash balance, and this is not in the budget, this is just cash management, if cash balance allows, we're going to propose moving more money over into board committed funds for the 27th pay period that will be coming in a few years. And we didn't do that last year. Also in the capital expenditures, there's $50,000 for 2 vehicles. We want to retire 2 older vehicles. So 2 new vehicles. There's $100,000 for security upgrades for the St. Mary's office and the Bonners Ferry's office. And there's about $145,000, if I remember correctly, 145, 160 for facility upgrades to Bonners Ferry. If you remember, late last summer, Don did a presentation. And we have not been able to do that. So that's included in this budget. So when we look at the budget as a whole, the fiscal year 22 budget is coming in at $14,145,000 compared to the revised budget of $14,006,000, a reduction of $500,000 or 4%. Now, I do want to say one thing more. If we were to back COVID, what we've anticipated for COVID expenditures, what we've estimated, if we back COVID out of that $14,145,000, we've estimated about $1,500,000 for COVID. If we do that, the budget without COVID is $12,500,000, which is really about a $178,000 decrease over the original fiscal year 21 budget, or a 1.437%, excuse me, not decrease, but increase. So it increases by about 178,000 or 1.43% if we back out COVID.
Mr. Chairman?
Yes.
You know, I need to thank staff and Christine. I mean, this budgeting is always a process that we put a lot of thought and time into. In looking at COVID, it's just, I mean, I know that there will be COVID activity in the FY '22 budget. I just don't know how much. I mean, currently we're at about 27, 28 FTE in COVID. So we took it down by about 10. I don't know if that's true or false. But we will keep you informed, and as we go forward, I mean, you guys are gonna see transparently what's going on with COVID and with immunizations and with numbers if we need to increase. I mean, we know that the ELC grant that we currently have is gonna continue into FY '22. I just saw today there's $7 million some dollars coming to the state of Idaho, and some of it will trickle down to local, I'm sure. I don't know how much. For workforce development and hiring of staff to help us deal with this. So I guess what I'm saying is there's a lot of I don't knows as far as COVID goes in this budget, but the rest of the budget is I think pretty solid and very similar to FY '21. I hope we can in FY '22 get back to the business of public health.
Unless there are further questions, that's the draft budget presentation.
Thank you, Christine. Any questions?
Mr. Chairman?
Yes.
I
Mike?
do have one comment. This relates back to an earlier topic on the agenda, with respect to House Bill 316 and whatever comes down the pipe. I'll remind us that are commissioners, when Laura comes and visits us, the amount that each county will be contributing may or may not depend on a state formula which we've done in the past, but may be something in a completely different form. I'm just asking us as commissioners to be ready for something different when Laura does her presentation.
Gotcha. That's kind of where I was going. In general, I see a lot of unknowns and uncertainties.
Mr. Chairman, there is one unknown. It's in the grand scheme. It's insignificant. The one thing that we don't know is insurance. I budgeted at the same rate as last year. I will probably go back and tweak that. One thing that is occurring at the state level, they're changing their reinsurance carrier. So that may impact the insurance rate that is filtered down to the health district.
And everybody knows that insurance rates are going down.
Absolutely. If there are no further questions, this concludes my presentation.
Thank you, Christine. That shows a lot of work and yet a lot more yet to come.
Yes. Yes.
No, I like the principle of paying down your debt.
Yes.
Getting that out of the way so we're not paying interest on it.
How often do you see 0% interest on $1,006,000?
Yeah,
Or
that's
600.
scary.
Yes.
Well, I'll bet you that bank doesn't make that mistake again. All right, thank you. Thank you very much. All right, we're going to move on to Laura with our director report.
Thank you, Mr. Chairman. JPAC did meet in February and approve our budget, but then we're on hold until we see what happens with House Bill 316. Kootenai and Benewah County Board of Health nominations, we will open those ballots. Usually we open them at our July meeting. We'll be opening them at our May meeting. So we've asked Benewah and Kootenai County to send us a name or names to put on the ballots. And then we'll get those out to the respective, to all of the counties for voting. Idaho Association of Boards, IAB, is held in, or is in Twin Falls. It's their turn this year. They have chosen to, it'll be a 2-hour business meeting only. It'll be a hybrid. So if you would like to go in person, you're absolutely welcome to. Just please let Jill know. It's a 2-hour meeting in Twin Falls. It'll be a business meeting only. They will have a Zoom or WebEx or GoToMeeting option. And in your packet, I did include the annual report for the public health accreditation year 2. So if you'd like to take a look at that, they said some nice things. And that concludes my report, Mr. Chairman.
All right. Sure, we're going to drive down to Twin Falls for a 2-hour meeting.
A lot of sagebrush to see.
All right. If there is no more business on the public scene in our public meeting, I will entertain a motion to go into executive session pursuant to Idaho Code 74-206B to consider the evaluation of a staff member.
Mr. Chairman, I would make a motion to go into executive session under Idaho Code 74-206, subparagraph B, to consider evaluation of staff member as stated.
All right, is there a second?
Second.
Roll call vote. Glenn,
Yes?
Commissioner Tim,
Yes.
Jay Nelson,
Yes.
Alan Banks,
Yes.
Dr. McClanders,
Yes.
Commissioner Mike,
Yes.
and I will vote yes. So while we discontinue our television